everybody came tonight. We're joined today with occupational therapist Dr. Joanna Behm. Thank you for joining us.
Yeah, thanks for having me. I'm happy to be here.
Great. Well, we all want to know how occupational therapy can play a role in our management of dysautonomia.
Awesome. Well, hi everyone. It is so great to be here. As Jennifer said, my name is Joanna Behm, and I am an occupational therapist and have been for, over 11 years now. And I am also a patient with dysautonomia myself. So I have hyperadrenergic POTS, I have mast cell activation syndrome, and I also have hypermobile EDS. And so the fun trifecta. Probably like most of you, I imagine the same story, medically gaslit for years and years, told everything was fine. I clearly was not fine as I was getting sicker and sicker. And so occupational therapy was really something that helped me figure out how to kind of manage my symptoms to the best of my ability. I really got sicker. I was always kind of sick, right? But I got sicker in occupational therapy school. And so as I was learning the profession, I was also implementing a lot of the things that I was learning. And that was basically keeping me in school and helping me be able to, still do the things that are important to me. My our plan for tonight, I'd like to tell you a little bit about occupational therapy, what we can do for dysautonomia in particular, and then I would love to just open it up to questions. But before we start, I would love to know, and you can do this by raising your hand, you can type in the chat, or you can, give me a thumbs up or whatever. Have any of you had occupational therapy before? Yeah, I'm seeing. Okay, so someone did, but unsuccessfully. Yeah, I've heard a couple of those stories. Yeah, most people are saying no. Yeah, so um, we'll talk about kind of what OT can do for you. I'm currently actually doing a research study right now, and we have been interviewing some individuals with dysautonomia, asking about their experiences with OT. And most people are kind of saying what you're saying, like, no, they haven't had it, or if they did have it, they didn't, it didn't work. They didn't have a good experience, so on and so forth. And so we're going to talk a little bit about, what OT can do, what it should be doing, what OT should be doing. But just like every other health profession, OTs don't know enough about dysautonomia yet. And I'm really working with some other occupational therapy colleagues of mine to change that. We're really trying because we are a population that could really benefit. So let me tell you a little bit about it. So, occupational therapy is a health profession that really looks at the whole entire person, right? And so, we are really dedicated to helping people do what we call occupations. And that doesn't necessarily mean work, it means anything that you do. And anything you do during your day, anything that's important to you, we consider an occupation. So, an occupation is just anything that occupies your time, right? And so, occupational therapists are really the experts on helping folks get back to or start doing things that would be really meaningful to them. So that could be work, but for a lot of us, that's not work, and that's okay. And so we are really looking at routines and habits and symptom management strategies, and adaptations, energy conservation. How can we still engage in things that we love, right? So I would love to hear from you. Again, you can type this in the chat, or if you want to unmute, you're welcome to. What are some activities that you really like doing but are hard to do because of your symptoms?
Going for a walk,
Yes, going for a walk. Oh, yes, me
walking my
too.
dogs.
Yeah, yeah, absolutely. Okay, we have someone in the chat saying playing with my grandkids, walking my dog. Yeah, absolutely.
I mean, to be honest, really everything. I mean,
Yeah.
working, breathing, existing.
Right?
Taking a
Right.
shower.
Yeah.
Yeah.
Did you say shower? Is that what you said? Yes. Oh my gosh, I know. Ugh, showers are so hard, aren't they? Yes. Someone in the chat said a lively conversation with friends. Yes. Yeah. Anything that takes energy, right? Driving, I know for some folks is hard. Driving's hard for me. I have kind of about an hour, hour and a half that I can manage, and once I get past that, it's exhausting, you know? Are there any other things that you like to do or want to be doing but are hard because of your symptoms?
I had started and I was so happy doing Pilates.
Yeah.
And once I started getting sick and I had to stop. So I haven't been able to do it. And I'm just really sad over that because it was something that I really enjoyed.
Yeah, absolutely. Yeah. Yeah. Someone else in the chat said hiking. Someone said, it's hard because doctors want us to exercise, but how? I'd love to go hiking or biking, but I get exhausted so easily. Preach. I know. I 100% hear that. I feel the same exact way. Someone said basic cooking and cleaning. Yeah, cooking.
Yes.
Cooking is so hard. Standing in the kitchen, right? Standing over something that's hot sometimes. Cleaning is exhausting, right? Walking upstairs. Someone said, so yeah, it's like all these occupations that we call or activities that we do during the day, they're really hard to do because we have an energy limiting condition, right? And our energy is so much smaller than I would say like a typical healthy person, right? And so occupational therapy is really saying, okay, I can't fix the dysautonomia in and of itself, right? Like we know that, but can we optimize our day so that we have more joy, so that our quality of life is higher, so that we can maybe get back to doing some things we like to do, but maybe we have to do it a different way, right? Maybe we have to change our mindset and change our expectations in on what is possible. And I will tell you, as someone who has the condition myself, and I'm trained as an OT, I still really struggle with that. I'm just going to be honest. Like I think it's really hard to change your expectations for yourself on like what is considered meeting the goal, right? And I think there's some grief involved in that because the version of your old self, for some of us, maybe we never even had an old self. Maybe we've kind of always been sick. But for a lot of us, we kind of have a pre and a post, right? And so it's really hard not to compare today to like back when we were healthier, you know? And so occupational therapy can also help kind of with those coping strategies. Interestingly enough, OT got its roots way back in the day. We became a profession in 1917. You didn't know you were going to get a history lesson today, did you? But we became a profession a long time ago, and we actually started out as mental health professionals. Interestingly enough, our profession started because we were helping folks who came back from the war kind of get back to doing things that they wanted to do, whether from physical illness or disability, amputations, injury, or the mental health aspects of dealing with war. That's actually where we started. And we found that by engaging in meaningful occupation, activities, things we enjoy, that helps people's overall well-being, right? And so what I love about the profession is because I know my condition, like I can't fix my condition. I do take medication to help manage it. But right now, I'll be honest with you, like it's not being managed by medication super well. Like I'm probably in a dip of kind of, this kind of highs and lows. And right now I've been in a low for a while, if I'm being honest with you. And so I find that occupational therapy can really help us emotionally manage the lows while, still having joy and finding things that we can do, and things that make us feel human and happy and not isolated and, part of the world. And I think that that's super important. So occupational therapy puts these different areas of occupation into categories. And so we have our activities of daily living. That's like the bathing, the dressing, the toileting, like the kind of like the basic stuff you do to take care of yourself. And then we have a category called instrumental activities of daily living. And this is like the higher level stuff, like the walking your dog, the going grocery shopping. We didn't even talk about grocery shopping. That's the worst, isn't it? Grocery shopping, driving. It's like that higher level stuff, right? And then occupational therapy also cares about your play. Like, are we playing? Do we have leisure? Or are we so exhausted because we're just doing the things we have to do and then we don't have energy for the things we want to do, right? I know sometimes that's my experience. So we care about leisure, we care about rest. How are we sleeping? What's our rest like? We care about social participation. Someone mentioned like conversation with friends. Like, are we engaging socially, right? Or are we isolating ourselves? Health management, how are we managing our symptoms and still trying to do things we want to do? And then of course we have work, right? But we look at everything we do during the day, and that's what we're really focused on helping people get back to. So we do that through several ways. We kind of have, I would sort of say, like two buckets, right? One is remediation, where we're trying to fix something. But for a lot of us, that doesn't work. So if you broke your arm would heal, and then you would get stronger and you get your strength and your flexibility back and blah, 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 right? Like that's easy-ish, right? I mean, still a broken arm. But with dysautonomia, a lot of times we can't fix. So we're adapting, we're modifying, right? And we can do that through changing the task, changing the environment, or changing, kind of the way in which we do something, or using maybe adaptive equipment, tools, things like that. So I think that when people have bad experiences with OT, which I'm not saying happens, I believe happens 100%. I think one, it's because the OT that they saw was not well educated in dysautonomia. And my other guess is they tried to go the fixing route, right? And you can't fix this, we can adapt, we can modify. Sometimes we can gain things back, right? But I can't fix the condition in and of itself. And so I think that that's something that's really important for OTs to know. And that's something that we're trying to work toward educating the profession on. Same with physical therapy, right? Like I think we need, physical therapists also, need to be more educated on dysautonomia as well. And so I think that it goes just beyond a profession. It's kind of like all health professionals, So that's sort of, kind of how we do things. I would say one of the biggest things that I do for myself is really energy conservation. And people say that phrase all the time and they're like, oh, well, just like sit down when you do something. It's so much more than that, right? Like energy conservation is really focused on, there's the 4 Ps. And so let me pull that up so I say exactly. Here we go. So there's kind of 4 Ps of energy conservation, right? So the first is plan. We'll talk about these in a minute. Then we have prioritize, pace, and position. So plan is like, how are you scheduling your day, right? Do you have a routine that doesn't use more energy than you actually have and spreads things out? If you overdo it on Monday, we all know Tuesday is going to be miserable, right? And maybe Wednesday and Thursday are also going to be miserable. So how do we plan our schedule and spread out difficult tasks throughout the week? Prioritize. How do we decide what has to be completed and then what can be delegated to other people or just doesn't get done, right? Like not every single thing has to get done. And as someone who is a type A person, that is hard for me because I think everything's important, but it's not, it's really not, right? And so prioritizing, what do I have to get done today? And what can I plan for later to do later, right? Pacing, this is breaking down activities into doable tasks, going at your own pace, taking breaks. This is something that I am just chronically bad at. I know how to teach it. I understand the concept and I have a hard time doing it myself. Partly because I'm not the best. I want to get one more thing done. I want to do one more thing. But as I've been feeling worse, I've been pacing more because I just have to. And gosh, it works really well. I wish I would naturally want to do it. If I can lay down or rest for even an hour, like that really does extend my quality of life throughout the day, and I know not everyone has the ability to like lay down during the day. Like I know that. And I don't have that ability every day, but some days I do. And so, when I do that helps. And then position. Are we having good body mechanics, good posture? Are we sitting when we can? Are we minimizing or adapting activities that require us to stand, squat, or bend for prolonged periods of time? Are we repositioning how we take a shower so we're not reaching over our heads for long periods of time? I don't know about you, but reaching over my head is something that really is triggering to my dysautonomia. So So that's one of the ways that we modify. The other way we modify is through adaptive equipment, right? There is always a tool that you can find that will be helpful, right? And so OTs are kind of experts at finding those tools that match you and fit you and what you want to do. That could be anything from a wheelchair to a shower chair. I'm telling you right now, if you don't have a shower chair, go get one. It is worth it. It is 100% worth it. Shower chairs are the best. Um, it could be something as simple as a hair drying thing that you can put your blow dryer in, and so you're not like trying to blow dry your hair. It could be something like that. It could be, just tons and tons of tools, and we can talk about all different types that are available when we open it up for questions. But I would say those are really the things that we kind of the adapting activity kind of focus that we have that I think that we can be really helpful in. So I'll stop talking now because this is meant to be discussion, but I at least wanted to introduce you to what OT is supposed to be, what it should be, what good OT looks like. And yeah, let's open it up for questions and let's chat.
So one of the issues I have in my area is most of our knowledgeable people are in the city center. I live outside of Houston by about an hour in Texas. And
Okay.
so a lot of the people in our area aren't very knowledgeable. So what would your advice be to help educate physical therapists and occupational therapists without, I guess what I'm trying to say, without making them feel like they're being challenged, because that's been a huge issue in my medical journey. I have a doctorate, and when I walk in, they automatically assume that I am talking down to them.
Yeah.
And I'm not. I'm really trying to be a partner in my health. So I
Right.
was interested in what you would have to share with.
Yeah, gosh, that's hard. And I think it kind of depends on the personality of your provider, right? And so I think that can we provide them with educational materials? And I guess maybe step one is, do they care? I actually think we need to back up. Do they actually want to learn? Because if the answer is no, you can provide education all day, you can be the perfect patient, and they still aren't going to want to learn, right? And so I would say step one is, do they want to learn? And if the answer is yes, that's great. Then there is a lot of continuing ed that is starting. It's very new, but starting to become available. Specifically now that long COVID is a thing. Like in my experience, a lot of therapists didn't really care about dysautonomia until long COVID, right? And now all of a sudden they're like, oh, huh, it's a thing. And we're like, yeah, we've been shouting this for forever. And so, so I think there's educational materials. And I'm not saying this to like sell you my book. Like that's not what so please don't take it like this. But the book that I wrote is, written from a fully occupational therapy perspective, is myself and another OT. And it's like every OT thing that you could do to help manage your symptoms. And that could be really helpful for providers. So I'm working with some providers at a health system, and they're going to start implementing kind of the workbook as part of their treatment plan, because the providers need some extra help and education. And I just think that's super cool that they're willing and care enough. The other thing is we have a lot of free resources on our website that you could provide them. And I think also, like, even if a provider doesn't know enough, if they trust you to listen to you about your body, I think they're really teachable, right? Like if you say, gosh, I can't do this today, and they push you, then my question is, do they really understand the condition, right? But if they say, okay, let's find a different way to do it, then I'm like, okay, that's great, right? Like we can work with that. And so I think my perspective is, can we find professionals that are eager to learn and care enough? And then it's a lot of educating, which is hard. And I should say that's not your job also. So I'm sorry that you have to do that.
Yeah.
But it is the unfortunate reality that we live in right now.
Yeah. I guess my pivot would be is my experience is that the people in my area do not want to learn.
Yeah.
I'm very well versed in dysautonomia. I've read research. That's my I'm
Sure.
a researcher.
Yeah.
And I've recommended like the Dysautonomia Project book I've recommended Dysautonomia International, and they're just not interested. And my
Right.
PCP is at her wit's end because she specializes in dysautonomia. And the
Ooh,
only
that's
option,
amazing.
yeah, I lucked out. It took a lot of trial and error. I just, I don't know how to get better because the people in my community aren't partners. And
Yeah.
so how can we get people on? I mean, obviously, my background's education. So if you don't want to learn, you don't want to learn. But are there tips that you would have that might encourage them? Because sometimes I find I'm not their peer. I don't have a medical background, even though research is my background. Um, but how can we navigate that and try to, because I genuinely believe like literacy is important. And if we can convince people or show them the legitimacy, they will likely come around. So what
Yeah.
would your advice be on that?
It's hard. I think it's a two-parter. I think there's like a short-term solution and like a longer battle, right? Like I think the short-term solution is there are some OTs that are doing this virtually that you can find out of state, out of your area that can really work with you one-on-one, that can really help you figure out what strategies are best for you. So I think that's like the short-term solution is to me, if you can't find a good therapist that's working well for you, find a virtual one. And most of the virtual ones have the condition themselves because they can't physically do a full-time in-person job, right? There's after this, you can reach. I can give you my email, and you can reach out, and I can give you some names. It's not me. There's other people. So that's a option for short-term solution. For long-term solution, I think Uh, I don't know if I have an answer for you. Like I don't know how to get people to care, right? I think it's so hard. If they don't care, they don't care. And I don't know if it's that they don't care. I think they're overworked and they are seeing way too many patients and it's not, it's not a great option. So I would maybe something you could ask is, hey, are you seeing any other patients like me? If so, like what's worked for them? And like, let me, here's why this doesn't work. Would it be helpful if I showed you the literature? Like, look, I know you're exhausted. I know you're busy. I know we're doing the best we can. Here are some strategies and some ideas that I saw. Would you be willing to do that? Can we try this together? And so I think it's worth a try, but it sounds like your current maybe providers aren't super interested in that. That's so challenging, Caitlin. I'm sorry.
I did link the dysautonomia handout in the chat box if anybody's interested in that. It's a great resource to print out and you can bring it to your provider to give them a better overview of how all-encompassing this illness is.
Yeah.
We do have somebody who asked in the chat box, how would you go about finding an OT provider that has experience in dysautonomia and what to look for in an OT provider?
Yeah. Um, Gosh, I wish I could just be like, here's everybody that's great. There's not that many of us that are doing this right now. But that's right now, right? Like it will get bigger, it will get better. But right now there's not a whole ton of us. I would say, the virtual option is a good option if you're willing and interested. Another thing that I would say is, when you call to make an appointment, if you want to see someone in person, when you call to make an appointment, I would literally say like, do you have any OTs that specialize in energy limiting illnesses, that specialize in long COVID, that specialize in, that phrasing sometimes is providers understand that more than like a dysautonomia or a POTS or I think if you can, everyone now knows long COVID. And so I'm not saying you have long COVID, but I'm saying like, can you say, does anyone have experience with these types of things? Does anyone have experience with orthostatic intolerance? That's a common phrase that people see because we see that in a lot of other conditions. Like people with Parkinson's disease have a lot of orthostatic intolerance. And so that's something that like everyone kind of knows about. They just don't realize that we have it. Right. And so I think I would ask before you go and waste your time because sometimes, specifically in outpatient, some of the occupational therapists are like strictly hand therapists. So they'll say, oh, we have OT at this clinic, but that OT is a specialist in hands, which is a great thing, not helpful for us. right? And so you really want to figure that out. If they have like even cancer rehab at their location, that might be a sign that they might know about that, because with cancer rehab, a lot of times it's energy conservation, it's, pain management, it's kind of chronic disease management. And so that might be kind of a little hint of, hey, these folks might know something about that.
That's great. And then with your book and your research study that you have planned for next year is going to really open up the field for many more occupational therapists to become knowledgeable of this for us.
We're hoping. Yeah. I mean, one of my goals is that, we have this workbook. It is meant for patients. And my hope is that then the next step is we create a provider one. That is just very clear cut and very, straight and to the point. Here's everything you need to know. Here are the assessments you should be doing. Here are the, here are some interventions that work, and kind of make it, as easy as possible for them. Because I remember when I was a full-time clinician and sick, that was very challenging, but I remember that. And, it was very hard. It was very hard because you're just, inundated with patients constantly, right? So there's not a lot of time to like sit and breathe and learn, because you're trying to survive your day, right? And like now that I'm in academia, I have more of that time and I can do more one-on-one stuff. But when I was a full-time clinician, that was hard. And so that's not an excuse by any means, but I just mean like our healthcare system is just really broken, right? And that's hard.
Does anybody else have any questions? Feel free to jump in.
You mentioned before about the different tools, adaptive tools. And, sometimes like you don't know what you don't know. So maybe there is a tool out there that could really help you. Is there a good website, a catalog, or someplace where we can explore and see what is out there and might help us?
Yeah, there totally is. I'm gonna give you the link. So on our website, we have a Thriving with Assistive Technology handbook. And so I'm gonna put it in the chat. And then it's the first link under handbooks. It says Thriving with Assistive Technology handbook. And so there's a lot. It's not like the all-encompassing every single thing ever, but I would say that has a lot of like the major common stuff. Another thing that you could do is, ask AI, ask Google, like, hey, I have this problem. AI would probably be better for this, like a chat GPT or something. Hey, I have this problem. What tools are out there to address it? And then you can kind of Google from there. But you're right. It's really hard when you're like, I have a problem with this activity, but I don't even know what could even help, right? So without an OT, I think that's an option. And then in the workbook, I do have listed like a bunch of ways to adapt things, but I would say the Assistive Technology Handbook, the free one, is more encompassing. It's bigger. So there's more in there for you.
That's great. Thank you.
I see in the chat that Jennifer asked, does insurance typically cover this, especially the virtual ones that may be out of state? So yes, insurance does typically cover it. Sometimes the virtual ones do not take insurance, but they can give you a super bill that then you can like submit to your insurance to get reimbursed, if that makes sense. So a lot of times they do that because our healthcare system is so broken, and insurance really limits what we can do in terms of how often we can see somebody, how many times we can see them. We have to validate every single thing we do and explain why, whereas like if you go outside of insurance, you can just do anything that person needs within our scope of practice, obviously. But do you know what I mean? Like you can kind of cover anything that person needs. It allows things to be a lot more holistic and a lot more person-centered. Like maybe you need to be seen or you want to be seen for an extended period of time. Like a lot of us with our insurance companies, like we get 12 visits max or something, right? And so when you go outside of insurance, that takes some of those limitations away. Typically with virtual ones, there's one person I'm thinking of in general, and I don't want to just give out her name because I have not asked her permission to do this, to do that. So I will ask her permission and then let you guys know. But she does it from almost a coaching model. So because of that, occupational therapy is regulated by state. And so like I'm in Pennsylvania, I can only see patients in Pennsylvania who live in Pennsylvania. So if you find somebody that does kind of a different model of occupational therapy where they're using the principles, but they're doing it in more of a coaching way, that also takes away some of the limitations. So our field is just limited a lot by rules in terms of, you know, insurance and then in terms of like our state practice act. So those are just things to kind of keep in mind. And then I see Anne asked, I frequently had referrals from my primary care doctor for PT, but they've never brought up OT as an option. What's the best way to broach the topic of OT with primary care? So I would say, I would just ask your primary care doctor, hey, I learned about occupational therapy. I'm wondering if it would be helpful for me to manage my daily life and to get some suggestions on ways to make things easier for me. Could you write me a script? I have never had a doctor say no. Most doctors are like, oh, yeah, okay. Like they just hadn't thought about it, right? So a lot of times it's not that they're saying, no, you shouldn't get it. They're just not, it's not popping up in their brain to suggest it. So I think you just ask, who is OT appropriate for and not appropriate for? I think it's appropriate for anybody that really wants kind of tips and tricks and ways to optimize their life and their day so that their quality of life improves. I think that some people have had this condition for a long time and just kind of have it figured out in terms of like, this is how I do things. This is what works for me. Those folks maybe don't need OT, and that's okay, right? But I do think it is helpful to just get an outside perspective of how do you optimize your routine? How do you figure out, you know, adaptive ways? Like maybe cooking is really important to you. OT can come in and say, okay, let's figure out how to make this easier. Let's figure out some solutions for you, right? And they're going to bring the medical knowledge with the energy conservation stuff along with the adaptive equipment, and they might be able to come up with a really good solution for you that maybe you just hadn't thought of. And so I always think it's worth trying for sure. And then the third part was recommendations before I have a formal diagnosis of dysautonomia. You can literally do it. I mean, if you have a diagnosis of anything, you can get OT. So if they say you have a diagnosis of, I don't know, I mean, I wouldn't be able to make something up because I don't know your health history, but like something some other medical condition, you need a medical condition. It doesn't have to be dysautonomia. But you can go in and say to an outpatient OT, like, I need help optimizing my routines. And you can say, I'm not here to like build up my, and, you know, maybe you are there for this, but you know, the way I would approach is like, I'm not here to like fix my fine motor skills or get stronger or, you know, or, you know, be able to walk longer right now. Right now, I need to get my routines in order. I need to optimize my life so that I can do things in the best way possible. And then when I have enough energy because I've optimized my routine, now I can work on trying to build strength. Now I can start working on endurance, right? But step one, we got to get through our days and we got to do it in a joyful way, right? Like this condition is so hard. It's so hard. And so like, are there ways that we're accidentally making things harder for ourselves? You know, and I think that's where OT can come in and give some suggestions. And it really should be a partnership. I should be able to say to you, hey, here's 3 ideas I have. And you're going to say, you know what? I tried 2 of those and they didn't work, but that one might work, right? And then we can try and go from there. So it is a little bit of trial and error just because everyone's needs are just so different.
Can occupational therapy help with cognitive function or executive, you know, functioning?
Yeah, for sure. Yeah. So I would say that if your goal is to improve your underlying cognition, speech therapy actually might be really helpful for you. Speech therapy is kind of like they're kind of the experts in that. Where I think OT is really helpful with cognition and executive functioning is with that adaptation and that routine. So like, okay, I keep forgetting X, Y, and Z, or I'm having trouble, organizing in my brain what I should do today, or I have a lot of brain fog and I can't get through a conversation, or, and then OT can come in and go, okay, let's try to modify that. Let's try to change that. Let's try something different. Like, let's try to figure out why we're having those symptoms. What are you doing before and after? And how does that impact you? Right. And then I'm not saying OT can't help you practice and get better at things and remediate. We definitely can. But to me, I would say, like, what I believe are kind of like special sauce is really saying, okay, we're going to have brain fog. I can't make brain fog go away a lot of times, but how do I make sure that I can still do things that I want to do?
Right. I also learned recently that speech therapists can help with the esophageal aspect of dysautonomia. A lot of us have difficulty swallowing, esophageal spasms, and a
Yes.
speech therapist would be somebody that you'd want to reach out to.
Yeah, speech therapists are great. They're really great. And I think they're another profession where I think that, like, their name doesn't necessarily like demonstrate all their skill set, right? Like occupational therapy, you think, oh, you're gonna help me get a job, right? But it's like, no, it's like your whole life. Whereas speech therapy, it's way more than just speech, right? They're the cognition experts, they're the swallowing experts, they're the, they're the speech experts, right? Like they have their hands on a lot of different kind of pockets. And so I have a lot of those issues too, especially like I have to kind of think to swallow, it's not like a nice natural reflex for me sometimes. So I choke a lot, and I probably could use some speech therapy myself, honestly. But yeah, they're the experts in that, and they're a great person to have on the team.
Yeah, me too. Do you have any strategies to help manage orthostatic symptoms?
Yeah. So I would say the research is pretty clear that compression works, and a lot of people that I know don't feel like it works. So it's I'm always hesitant to say everyone should do compression, because I think if it doesn't work for you and your experience, like I'm not gonna tell you something else, right? So I think number one is potentially compression. I guess where I would start is, why are we having the orthostatic symptoms, and is there something we can do about it? Are you hydrated enough? Do you have enough sodium? Are you wearing compression if it works for you? Do we need a medication change? Right? Is it that, you need a medication to help with that? If all of those things are handled medically, then I think that's where OT comes in, right? Because again, I can't give you medicine. You're going to get that from your doctor, but then I can say, okay, even on this medicine, we're still having some orthostatic intolerance symptoms. Why is that? And is it that you're standing up getting ready in the morning and you don't realize how much you're standing? Can we sit more to get ready in the morning? Can we decrease the amount of steps that your morning routine takes? So for some of us, we get up in the morning and then we like go to the bathroom, we get in the shower, we get dressed, we do our hair, and like an hour goes by and I literally just did an hour of essentially exercise for myself, right? And like I didn't even realize I did that, and I didn't hydrate first. Like, is that something? I don't know, right? And so I think for every individual person, we'd have to figure out like the why. But I always tell my students, like, occupational therapists are detectives. Like, we should be figuring out exactly what the problem is and then addressing that. We do something called activity analysis. And so we look at an activity and we look at every single step of that activity and we figure out why something is not working or what the problem is. And so I would do the same thing with orthostatic intolerance, right? Sometimes it's as simple as you need to sit, right? Sometimes it's, you're doing an activity where your arms are above your head. That's gonna be challenging for you. We should stop that. Maybe sitting isn't enough. Maybe I actually need to be reclined a little bit, Maybe it's that I need to be showering at night instead of the morning. Maybe I need to set up my morning routine so that I'm doing less stuff. So my clothes are already set out. I showered the night before. I did my hair the night before, if that's possible. Not everyone can do that, right? Depending on their hair texture. But, are there things that we can do to make that morning orthostatic intolerance better? For the afternoon, does caffeine work? For some people, caffeine's super helpful. For some people, it's like their worst enemy, right? For me, it helps me, right? And so can I have some caffeine? Can I, if I can even lay down for a little bit, that is enough. That helps me, right? But am I standing for things I don't need to be standing for? You know, and a lot of times the answer is like, gosh, there's so many parts of our day where we're doing that. And maybe we don't need to be all the time, right? But we can still move. Like for a lot of us, if we're moving, it's not as bad as if we're just standing there, right? So I'm not saying sit and do nothing all day, but I'm saying, can we not just like statically stand there for long periods of time, right? Because that's going to be our biggest trigger. So yeah, so long story short, I think we'd have to figure out like why it's happening, but then we could definitely come up with lots of solutions.
Regarding
Right.
compression, how tight should like compression socks be? Or like I don't know, I'm new to this, and I got some and it felt so uncomfortable that I had to take them off. So how tight should they be? What's too loose or what's, not tight enough?
Yeah. So two parts to that. One, I would say, were they too tight because they weren't fitted to you? Like we want to make sure that if like they fit you, because there's different sizes. So there's different sizes you need to consider, and then there's also different levels of the compression. So how tight they are, right? So if you got one that the compression was right, but it was too small, it would feel terrible, right? But maybe if you got one the right size and the compression was too much, that could also feel bad. So it's kind of a two-part thing. You can actually get
I don't
like
know. I ordered them from Amazon.
right. Yeah. And so a lot of times you can measure your calf, and that will tell you, like on Amazon, it'll tell you like how, if your calf is this many inches or centimeters wide by this size, I typically go to 20 to 30 milligrams of mercury. So that's like how tight they are. I usually do a 20 to 30. Some people can do 30 to 40. I can't. It's too tight for me. And so it could be something, start with 20 to 30, see how that feels. There's also less, there's like 10 to 15. And I will say, some compression is better than no compression. I think researchers wouldn't like that I say that. I think researchers would say, no, like this is the best and this is what you should do. They also say that like the thigh high, waist high compression, like the pants one, those are the best. I cannot tolerate those. I have too many GI issues. I don't want anything tight touching my stomach, right? So I wear knee highs. And so when I wear them, right? I'm not the best at it, but I wear knee highs. And researchers would say that is not optimal. But as an OT, I would say some is better than none, right? They do help me a little bit. Would it be more helpful if I did the full waist? Sure. But I can't tolerate it. So
Should they be worn all day, all night, or just all day?
typically not at night when you're sleeping. So typically during the day. So when you wake up in the morning, you can put them on. You'll just want to make sure that they're not too tight. Like they shouldn't be leaving marks on your skin. They shouldn't be causing you any pain. You should kind of just get used to them. So if you're finding you're not getting used to the compression, then they might be either a little too small or a little too tight. And then typically you don't want to put them in like you can hand wash them. Because if you put them in the washer and the dryer, then like it loses the correct elasticity. So that's something to consider too. Yeah.
Thank you. That was very helpful.
Yeah, sure. Okay, so Anna asked, what does a first OT appointment or first few appointments look like? What to expect going in? What information to bring? I'm so used to doctors feeling my case is so complex, so meeting a new provider is stressful. Preach. Yes, I know. It is. It's stressful. I think what's kind of cool about OT is, and I don't want to say the diagnosis doesn't matter because it does, but the reasons why you're struggling is what matters more. So, for example, like if they can understand that you have orthostatic intolerance and we can't really fix that in OT, we can fix that in medication can help, compression can help, but like my strategies aren't going to fix that. I'm going to adapt that. So if they understand I need to adapt, this is an energy limiting condition, even if they don't know the ins and outs of your complex condition, they can still be really helpful because we're looking at function less than like the chemistry and biology and anatomy of your specific complex conditions. Does that make sense? So like, not that we don't care about that, we do, but I care more about like, you can't shower. It's too hard. You can't cook. You can't go on a hike with your friends, and that's really important to you. How do we help you figure out how to do that? And so I think OT is a good, safe place to land, because if you don't have a formal diagnosis, if your medical history is really complex, like I imagine most of ours are, right? I think it's a kind of a good, safe profession to start with. The first session, you'll have an evaluation. And so they'll do a bunch of tests on you, to kind of see where your baseline is. And then you'll create goals together of like, what do you want to get out of this? What are we trying to work on? And then you start working on them the first few sessions. And then they'll do a progress assessment every so often to say, hey, are we meeting these goals? Are we working toward them? Do we need more goals, different goals? And then we kind of go from there.
I know we had a patient here who was late for joining us because she was sitting on the floor in Walmart. I wanted to ask you, do you by
I've
chance
been there.
have access to a rollator, or would you be interested in some kind of mobility device? Maybe Joanna, you could give some advice on those.
Yeah. Okay, so researchers also probably went like this answer. And I say that as a researcher myself. I think mobility devices are amazing, and I think we should have them. I really do. I think that professionals, a lot of doctors get nervous because they're afraid we're going to decondition, right? And my response is, yeah, but if I'm not exhausted, then I can actually do some exercise, right? Like I have a wheelchair. I have a handicap placard that I use sometimes. I don't use it every day. I use it when I need it. I don't use my wheelchair every day, but I use it anytime I need to walk far, or I use it when I want to go to an amusement park, when I want to go to a museum, when I want to travel, when I want to walk on a boardwalk at the beach, whatever, right? Anything like that, that will, if the activity will bring me joy and my symptoms will make me miserable, use the adaptive equipment, use the wheelchair, use the walker, right? A rollator is great, because it is, you kind of hang on to it. It has like the brakes and the hands, and then you can kind of push it, and then it has a seat on it and you can sit. So my response to this near syncope vasovagal episode, which gosh, I hear you and I have been there. Is sitting enough, or do you need to lay? Because if sitting is enough, a rollator might actually be really helpful. But if that is not enough, then do we need to look at, a wheelchair for some outings? Do we want to look at a scooter? Do we want to look at maybe still a rollator, but then if you can sit more often on your trip, does that then prevent the episode? If you're sitting on a rollator, you're closer to the ground, and that's safer than just standing, right? So I think there's lots of options for sure.
Yeah, a rollator gave me back so much independence, and initially patients I know are very uncomfortable using these kinds of devices, but once you feel the independence that it provides for you, I think that goes to the wayside. And like Joanna's saying, the joy in your day, when you're dealing with something this tough, that's what you need to look for.
Yeah. Totally. And I think that all of us have some, maybe you don't, maybe you're more, I don't know, adapted than I am. But I think for myself, I can say for myself, like I even still to this day sometimes have a little internalized ableism where I'm like, oh, do I really need that? Should I use this? I don't know. Like, I don't want the attention. I don't want, people act weird around me, and I don't want to deal with that. And then, but I would always say, like, if a patient said that to me, I would say to them, like, who cares what those people think? Go do what you need to do to have a good life, right? And so I just want to hear, if you are nervous about it, that's also okay. It's totally fine. I would say if you're gonna use a cane or a rollator or a walker, get it fitted to you. If you don't have somebody to fit it, the key is that the handle should be at your wrist crease when you're standing. So when you're standing up and your arms are at your sides, the handle should be right about at your wrist crease. So a lot of times we have them up a lot higher, and then our shoulders are hiked, and then we wonder why we have neck and shoulder pain. So if you can lower it a little bit, try that and see if that helps. And then you can adjust it as you need to, but that's always a good tip, I think. But like for me, I'm not concerned about deconditioning. I'm concerned because when I do use it, then I have energy, or at least a little more, to then like do things, you know? And so then I can exercise and I can do things that I like to do. And to me, that's the point of life, you know, to at least enjoy what we can, you know?
Well, I guess we're going to wrap this up for the night. Thank you so
Yeah.
much, Joanna. That was a wealth of information and opened eyes, you know, for these patients that didn't know how occupational therapy could be of assistance to them.
Yeah, of course. So just hang in there, everyone. I know we're all doing the best we can do, and I wish you a nice, restful, good evening.